Good morning, everyone. Today, the topic of discussion for General Club is efficacy of reduced intensity chemotherapy with oxaliplatin and capecitabine on quality of life and cancer control of the older and frail patients with advanced gastroesophageal cancer, the GO2 phase 3 randomized clinical trial. As per trial, gastroesophageal carcinoma is the third most common cause of death in North America and Europe, with more than half these deaths in people over 75 years, many of whom are frail and with comorbidities. This was published on May 2021. According to Globocan 2022 India, it is the fifth most common carcinoma is carcinoma esophagus, more in males than females, followed by colorectal carcinoma, followed by stomach carcinoma. And also it shows that it is more in middle-age group. The given pie charts are from the Globocan 2022, which shows that in males, the third most common is the esophagus, followed by colorectal carcinoma, and then stomach. The already existing trials are usually done in the patients which are fit and not very frail. Since the evidence guiding the treatment for vulnerable old patients is poor, certain trials were designed for the frail and older patients. The first trial to introduce overall treatment utility was MRC Focus 2, which was done in 2011, which used the 80% dose reduction and compared them and introduced the novel endpoint that was overall treatment utility, which included um, uh, the patient acceptability to the treatment as well. Further taking this, in 2017, 3-1 GO trial was done, in which 3-drug regime, 2-drug regime, and 1-drug regime were taken as 3 arms, in which the 3-drug regime was epirubicin, oxaliplatin, and capecitabine. The 2-drug regime was oxaliplatin and capecitabine, and 1-drug regime was capecitabine alone. It was found that the patients which were given the 2-drug regime showed better response, and hence it was selected for the vulnerable old patients. Further taking this, the GO2 trial, which we are going to discuss today, was done in 2021, which was done for the dose optimization of oxaliplatin and capecitabine in frail patients. The GO2 trial at a glance. The study is GO2 trial. The design is phase 3, multi-center, open label, randomized non-inferiority trial. The population taken is older and frail patients with untreated advanced gastroesophageal cancer. The sample size is 559 patients, median age 76 years. Severely frail patients taken in this trial was 58%. The intervention is oxaliplatin and capecitabine at 3 dose levels. The levels were level A, oxaliplatin at 130 milligram per meter square plus capecitabine 625 milligram per meter square BD. Level B was 80% of level A and level C was 60% of level A. The primary endpoint was progression-free survival. The key secondary endpoint is overall treatment utility, OTU. Non-inferiority margin was taken as hazard ratio of 1.34, 34-day acceptable progression-free survival loss. The PFS results of B versus A hazard ratio is 1.09, while C versus A, the hazard ratio came out 1.10, both of which were which showed that it is non-inferior, but the results were not significant. The overall survival result, no survival benefits were seen from the higher doses. The OTU results were better with level C, and the toxicity was lowest in level C. The main conclusion is that reduced dose chemotherapy preserved efficacy and improved patient experience. As discussed in the previous slide, the trial design is phase 3, randomized, multi-center, prospective, controlled, open label, and non-inferiority trial. The aims and objective of the trial were to establish the optimum dose intensity of 2-drug palliative chemotherapy for advanced GO cancers to achieve the best balance for cancer control, toxicity, patient acceptability, and the quality of life for patients who are not considered suitable for 3-drug chemotherapy. Also, to establish pre-treatment patient characteristic in individual patients which predict for better or worse outcomes with chemotherapy at different dose intensities. The given picture shows what is the standard treatment, that is epirubicin, oxaliplatin, and capecitabine, while the adaptive treatment for failed patients was oxaliplatin and capecitabine. The baseline patient characteristics included age, gender, WHO performance status, frailty and age, um, squamous histology, and site of primary tumor. The frailty score included 9 individual domains. The frailty score included 9 domains, which included BMI, weight loss, mobility, falls, cognition, status, function, social care, mood, fatigue, and polypharmacy. If the patient had 0 or 1 of them, it was taken as a mild frailty or no frailty. If it was 2 out of 9, it was taken as intermediate frailty. And if the patient had 3 or more, it was taken as severe frailty. The inclusion and exclusion criteria included inclusion of all the criteria was necessary. Histology or cytology confirmed carcinoma esophagus, gastroesophageal junction, or stomach, with or without distant mets. But if M0, the patient was being treated with palliative intent, considered by the treating physician to be fit or suitable for any of the GO2 regimes. Renal function, the GFR must be above or equal to 30 ml per minute estimated or measured. Hepatic function, the bilirubin must be less than 2 times the upper limit of normal, and AST or ALT should be less than 5 times upper limit of normal. The bone marrow function, absolute neutrophil count, should be above or equal to 100 into 10 to the power 9 per liter. Written informed consent was taken. And female participants of childbearing potential or male participants who are sexually active with a female of childbearing potential must be prepared to use contraception during chemotherapy and for 6 months after completion. The exclusion criteria, if any of the criteria was there, the patient was not fit for a GO2 trial. If the patient is fit, suitable, and willing for standard full dose combination chemotherapy with EOX or equivalent, previous palliative chemotherapy for GO cancer was taken, medical or psychiatric condition impairing ability to consent or comply with oral chemotherapy or trial assessments, other malignancy, if in the opinion of treating physician, this would significantly impede the interpretation of the outcomes of trial treatment. Age less than 18 years and pregnant or lactating. If any of those were present, the patient was not included. The randomization was done at 2 levels, the chemo intensity and the chemo BSC level. After the patient selection and consent taken, the baseline assessment was done, and the patient or clinician consensus decided whether the patient has to be taken for chemo intensity or chemo BSC. BSC being the baseline supportive care. Uh, in the base chemo intensity, there were a 3-way randomization of oxaliplatin, capecitabine level A, oxaliplatin, capecitabine level B, and capecitabine level C, which are shown here. Level A had 130 milligram per meter square oxaliplatin dose and capecitabine 625 milligram per meter square dose. Level B was 0.8 times A, that is 104 milligram per meter square oxaliplatin and 500 milligram per meter square capecitabine. Level C was 0.6 times A, that is 78 milligram per meter square oxaliplatin and 375 milligram per meter square capecitabine. The chemo BSC level were decided were divided in 2-way randomization, level C and BSC. BSC being the supportive care, and level C was the same dose which is given in this table. Evaluation was done. The imaging was repeated every 9 weeks. Imaging included the CT images. Evaluation was done according to two parameters: overall treatment utilization and longitudinal quality of life. Overall treatment utilization, the score was done once 9 weeks after starting the chemotherapy. Cancer status, toxic effect, serious adverse effect, quality of life, and patient value and acceptability were evaluated. Cancer status was evaluated using the CT images and clinical assessment. Toxic effect were evaluated according to the CTCAE criteria. Serious adverse effect were evaluated. Quality of life was evaluated according to QLQ C30 questionnaire. The patient value and acceptability were decided according to the two questions asked to the patient. The question number one being, since you started chemotherapy, how worthwhile your treatment has been? And the question two being, how much has your chemotherapy interfered with your normal day activities? The longitudinal quality of life included EQVAS, which was done weekly, EQ5D, which was done every 3 weeks, and QLQ-C30, the fatigue subscale, which was done every 3 weeks during chemotherapy and then once every 9 weeks till a year of randomization. The graph shows the same, that 3 cycles of chemotherapy were given, after which week 9 post-randomization, the assessment was done. If benefit, the treatment was continued till the clinician or patient decides to stop. That is, benefit was described as no radiological progression or clinical evidence of cancer progression. And if there is no evidence, the chemotherapy trial was stopped or it was managed off trial. At week 9, limited health assessment questionnaire was given, which was described earlier for OTU. Continue chemotherapy until progression, unacceptable toxicity, or clinician patient decision to stop. Further imaging was continued at week 18, 27, 36, and 52 post-randomization, that is every 9 weeks. For longitudinal quality of life, the patient was assessed at week 9 and then at week 18. These are the toxic effects which were reported within 9 weeks of the starting chemotherapy, which were maximum in level A, fatigue being in 86% patient of grade more than equal to 2, and non-hematological side effect or toxicity in 125 patients, which was seen that it reduced in level B to 116, level 2, and 58 in level 3, grade 3, and fatigue in 72 patients and 20 patients of more than 3 grade. The level C fatigue were seen in level C fatigue were seen in 67 patients of grade more than equal to 2 and in 18 patients of grade more than equal to 3. Any non-hematological was seen above more than grade 2 in 101 and in 38 patients more than equal to grade 3 in 38 patients. The chemo VSC level showed much lesser toxicities in level 2 or in grade more than 2 or grade more than 3. The summary of the best responses in level A, level B, level C, level A versus B and level A versus C is given as follows. The disease control was seen in 86 patients in level A, was seen in 69 patients in level B, and in 70 patients in level C. In both of the comparison, level A versus B or level A versus C, it was seen that disease control was better in level A dose given than the level B or C. Complete response was equivalent in both the comparisons, and progression of the disease was more in level B versus level C as compared to level A. The outcome of the chemo intensity was decided, the primary endpoint being the investigator-determined progression-free survival using permissive boundary of 34 days reduction in PFS with hazard ratio of equal to 1.34. The key second endpoint was overall treatment utilization, which showed the patient experience. Good overall treatment utilization was explained as no radiological or clinical evidence of progression or no other negative factors. The intermediate overall treatment utilization was seen as cancer progression or at least one negative factor present. If any of one of those was present, the patient was kept in intermediate overall treatment utility. And the poor outcome was that evidence of cancer progression plus at least one negative factor or the patient died during the study. The chemo BSc level outcome were measured as primary endpoint being the overall survival and secondary endpoint being the patient reported fatigue and quality of life. This is the stacked bar chart subgroup analysis, which shows the influence of baseline factors at dose and dose level on overall treatment utilization. The reference being the level A for all the studies. The hazard ratio that odds were the odds were calculated as 1.15, that is, it is 15% worse than the reference, and level C of 0.81, that is it is 19% lesser odds of getting worse. But since p-value was 0.49 and 0.28 for both of the tests, it is non-significant. Similarly, age less than 75, age more than equal to 75 groups, patient PS01 and PSL more than equal to 2 levels were checked, and similarly non-frailty or slightly frail and severely frail levels were checked. Only severely frail group, none of those showed that it is significant. In the univariate analysis, impact of baseline variable overall treatment utility, there were only distant mits present, which showed that p-value was significant and showed worse outcomes. Then further, WBC, if more than 11 into 10 to the power 9, showed that this has worse outcome than the other baseline characteristic. Neutrophil lymphocyte ratio more than equal to 4 was significant for the assessment of worse outcomes. The platelet, albumin of less than 30 gram per deciliter and urea of more than 6 millimole per liter were also significant for assessing the baseline patient modalities. Percent present with OTU score at 9 weeks were assessed, and only frailty and function impairment, QOLVAS less than 50 and QOLEORTC GSS less than 41.6 were seen to be significant. This is the statistical analysis among the 3 levels of chemo intensity, which show on the x-axis there is time since randomization, on the y-axis there is proportional alive and progression-free survival of the patient. The blue line shows level A dose subgroup, the level B is yellow line, and the level C is the light blue or sky color line. All the 3 lines showed similar results and overlap, which shows that progression-free survival was similar in all the subgroups. The chemo intensity overall survival was also showed similar outcomes in all the 3 levels. In chemo BSc overall survival, the basic supportive care patients, which are represented as blue line, and basic supportive patients which received the level C chemotherapy are shown by the yellow line. It shows that basic supportive care level C patients showed a better response than the basic supportive care patients only. This is the consort for the diagram. 514 patients were randomized in chemo intensity pathway. 170 in level A, 171 in randomized to level B, and 173 randomized to level C. Out of 170 randomized to level A, 161 received level A treatment and 9 received no treatment. Since for intention to treat analysis, 170 patients were included, whether they received the treatment or not. 142 progressed or died, and 28 were alive and progression-free at the end of study. In 171 randomized patients to level B, 163 received level B treatment, 8 received no treatment, 171 were included in the intention to treat analysis, 147 progressed or died, and 24 were alive and progression-free. 173 patients randomized to level C, 168 received level C treatment and 5 received no treatment. 173 included in intention to treat analysis, 149 progressed or died, and 24 were alive at the progression-free survival. It is seen that all the three levels were randomized in 1:1:1 ratio, and the progression-free survival is almost equal in all the three. Sorry, progression-free survival is almost equal in all three. In chemo BSc pathway, 45 patients were randomized in chemo BSc pathway, 23 randomized to level C, and 22 randomized to BSc level C. 18 patients received level C treatment, 5 received no treatments, 23 were included in intention to treat analysis, out of which 17 died and 6 were alive. And 22 patients randomized to BSc, 22 were included in intention to treat analysis, 20 progressed or died and 2 were alive. This is the forest plot for chemo intensity progression-free survival of level A versus level B, which shows that the results were better or in favor of level A because the hazard ratio was crossing the line 1. For in cognition and hemoglobin, if less than 12, other values did not show any significance. For chemo, forest plot for chemo intensity progression-free survival level A versus level C, baseline GSHSQL less than 41.6 shows that it showed better results with level C, and other which showed better results with level A were gender female, dose reduction, site of primary tumor was geo junction, weight loss or BMI was more than 18.5. Cognition was present. Cognition was taken as Alzheimer's here. So if the patient did not have it, it was taken no, and if yes, then the patient benefited from level A treatment. Hemoglobin less than 12, if yes, and patient more than platelets more than 400 benefited from level A. Forest plot for chemo intensity overall survival level A versus B shows that cognition, baseline pain, baseline odynophagia, and PNP more than 100 showed better results with level A. Other values were not significant. Forest plot for chemo intensity overall survival level A versus level C showed that for cognition, baseline BAS less than 50 and platelets more than 400 showed better results with level A, and baseline GHSQL less than 41.6 showed better results with level C. Chemotherapy delivery and tolerability. The patient was started out of level A out of 170 patients started treatment. Patient who started treatment were 161. 63 patients required dose reduction, and 53 patients were stopped for toxicity. 18 patients tolerated treatment but stopped before cycle 3 because of cancer progression or death. The patients who completed the intended dose without delay, or that is more than 1 week, were 51 in level A. In level B, it was 72, and in level C, it was 97. It is seen that dose reduction was which was required for maximum is level A group, while the patients who completed the treatment were maximum in level C. Factors which were associated with overall treatment utility outcome in multivariable analysis and showed that they were significant were frailty, severely frail versus not or slightly frail, baseline VAS less than 50, yes versus no, neutrophil to lymphocyte ratio more than 4, yes versus no. The results of chemo intensity and chemo BSc level were as follows. Non-inferiority progression-free survival were confirmed for level B versus level A, hazard ratio being 1.09, 95% confidence interval. Since the value is crossing 1, it is not significant. Level C versus level A hazard ratio was 1.10. It is also non-significant. Overall survival B versus A hazard ratio was 1.09. Again, the results were non-significant. C versus A hazard ratio was 1.14, the result being non-significant. Level C produced less toxic effects and better overall treatment utility than level A or B. No subgroups were benefited from higher doses. In chemo BSc level, overall survival was non-significantly longer with chemotherapy. Median survival of 6.1 months versus 3.0 months in chemo level 3 versus chemo BSC, not receiving level 3. Hazard ratio being 0.69. The values were again not significant. The discussion points were lower chemotherapy intensity does not compromise cancer control. Lower dose, that is level C, produce the best overall patient experience. More chemotherapy is not always better. Frailty assessment should be incorporated into routine oncology practice. Treatment decisions should prioritize patient-centered outcomes. The conclusion being the goals of palliative chemotherapy in older and or frail patients, including but not limited to cancer control, may be better achieved using treatment at doses well below those currently regarded as standard. Careful baseline geriatric health assessment in oncology clinic can help predict the likelihood of achieving those goals and so contribute to patients and clinicians' treatment decisions. Assessing the outcome of cancer treatment should be multidimensional, including its value to patients and its adverse effect. And if we recommend further development of the overall treatment utility to capture this complexity. The GO2 trial offers a design paradigm for enhancing older patients access to research and ensuring that our evidence base embraces the whole population that we serve. Thank you. Frailty had 9 domains. Uh, Weight loss of it was described as BMI of less than 18.5. Then there was mobility, which was tested as test up and go test. Then mobility के लिए they have used, sorry, there is a up and go test for mobility. At a distance of 3 meters, there is a line placed, and the patient is asked to sit and lean back on a chair of width of 45 centimeters. Timer is started and the patient is asked to get up from the chair and walk to the line and come back and sit on the chair again. If and the time was evaluated. If the patient throughout the study showed deterioration or increment of the time, the mobility was said to be decreased. Now, baseline of the patient. We will take हाँ जी मैम नहीं मैम मैम फ्रेल के लिए 9 डोमेन्स हैं हाँ जी हाँ जी यस मैम baseline से डिस्क्राइब किया है Now third domain is falls. The patient falls. How many falls was it? Yes. Yes, I think it's going by if the patient falls or not. What it was given in trial was that if out of 9 domains, any 1 or 2 is there. not aware of it. Cognition with Alzheimer's, if Alzheimer's is present or not. Yes, it would be also. हाँ जी मैम, sorry मैम, mild dementia is there. If yes or no का parameter दिया हुआ है. Yes, ma'am. False. Ma'am, then function was there, social care if provided or not. Function. Then social care if patient कितना कितना हमसे काम कर पाते हैं. Function activities of daily life कितना हैम्पर हो रही है उस पे उन्होंने किया. इसमें most of the things are subjective in this. Clinician decided ज़्यादा है इसमें. Ma'am, ECOG 0 if the patient has no functional impairment. So, but the patient does not have any impairment in daily activities and can swim his activities. Symptom within symptom and actually more than 50% activity of the walking was not multiplying it. Move. Yes, patient move. Fatigue. Patient reported fatigue here. Polypharmacy, if there was any other treatment being taken. फेरिटोनिन के लिए तो दिया हुआ है. Yes. Yes. तो इसलिए हमने स्टेमस किया होगा तो जैसे एडिनो होता है तो एडिनो हम से टारगेट है वो आप एडिनो बताते हैं एडिनो में अगर मल्टी पॉजिटिव आ गया तो वो इसमें भी ये Gastroesophageal junction is the point where the cells, smaller cells of polymer junctions. 2 centimeters above the 5 centimeter below. Yes, sir. So, type 1, type, yes, sir. So type 1 is more than from 2 centimeter to 5 centimeter from G junction is C1. Then from below 2 centimeter and above. So type 2 is from 1 centimeter above the G junction and 2 centimeter below G junction. Type 3 being from 2 centimeter below G junction to 5 centimeter. Next one, G. Well, to calculate one is to calculate the physics. Toxic is so सारी grade को equal या higher grade में तो ज़्यादा score होगा. Of all those, if any of them is present, then it is taken as if along with treatment progression it is there, it is taken as poor overall treatment utility. And if हाँ जी, grade 1 नहीं हो रहा, grade 2 3 है. हाँ जी, इसमें दिया because of dose reduction, they also explained in this dose reduction chemical levels पे करना है. Toxic effect. Yes. The toxic effect will start with specific 2 and 3. One four of that. One it's not giving the dimension. One is not taken above that distance. Question again. Next question. इसका आंसर yes no. Yes no. How much has zero? Maybe yes no. How much was patients say not very much and this is a one. मम इसमें इतना ही दिया है yes no. हाँ जी. Yes no का ही दिया होगा. Yes. Yes no. How much सही है मैंने मतलब यस नो का ही दिया इसमें और तो ऐसे कुछ नहीं इसमें किया मैम पेस्ट को इसमें only two things are seen. If no radiological evidence of regression and no other negative factor is there, then it is good OT. If the cancer progression is there or there is any one of the negative factor present, then it is intermediate. And if evidence of cancer progression plus there is one negative factor, or the patient died, it is taken as correct. VAs being the visual analogs. Analogs. Ma'am, that the level B was not better than level B. That the disease progressed. तो कंप्लीट रिस्पॉन्स में 8.3% ज्यादा पार्शियल में 18% ज्यादा था स्टेबल डिजीज stable disease. Now in level A it was better than level B. Better for now in 27 patients was in level A were of stable disease and while it was 27 patients of level B, but percentage wise देखेंगे तो 42% partial disease के partial response show करते थे level A में, while 24% only showed A intervention showed better results than the intervention. Plus me minus the minus minus 7% we become में minus level minus eight previous start that this was analysis. Now the OTU के basis पे they go intermediate and poor OTU they are bad far. और रेड वाला काउंट लेकिन इसका मुझे दूसरे से लास्ट की वैल्यू है ना जी नहीं है lower dose does not income because this is non-inferiority. It shows that level C is it does not give worse outcomes. level therefore not significant. Normally, because it is 0.89 to 1.32, it touches one. Now, we see that if the range of confidence interval touches one value, it touches the one value, it is not significant. Yes. Because the p value was 0.3. Why? Why? So why? Why? Because good or bad? Now, if the confidence interval is shorter, it means more number of patients or sample is taken. Why confidence interval is good or bad in this class? Why? No, less number of samples. What is the important? Like why is the wider confidence interval bad? Confidence interval is what's the problem? Is the range from which points are taken parameters.
यदि confidence interval का मतलब ये है कि जो repeated value वो आपकी clustered नहीं है, बहुत widely distributed. Therefore, one patient is getting benefited, other patient is not getting benefited, और वो बहुत ही widely distributed range जो है वो बहुत wide. कोई भी जैसे आपने कोई टेस्ट लगाया, तो उसकी repeated value अगर एक ही जगह पर fall करती है, हर बार consistency of results बेटर होते हैं अगर शॉर्ट कॉन्फिडेंस होता है अगर वाइड होता है तो रिजल्ट ऑफ द स्टडी इज नॉट कंसिस्टेंट बहुत वाइडली वेरी कर रहे हैं
तो इसलिए और बहुत आप सही करिए प्रैक्टिस बहुत अच्छे से पर सामने जाओगे या सोबत कुछ पेशेंट को नाइट और मॉडल करते हैं और दोनों बैठे के हॉस्पिटल विजिट्स जैसे फाइव ऑफ
Recently,